to get underway here pretty soon. Just let everyone, give them some time to settle, grab some food. All right, good afternoon, everybody. It's just about 8 minutes after 12, so let's get started on the second ad hoc committee on EMS response. Before we get underway, as we know from our first meeting, national EMS systems right now are primarily focused on responding quickly to serious accidents and critical emergencies. But what's going on is patient calls are for less severe chronic health problems. Okay, and so that's beginning to take up some of that available capacity. City Council is now having to engage in that conversation on response times, and that's something that we're going to cover today. And we're going to have to eventually figure out what that policy is going to look like and what works best for a city and best serves our residents. So again, what we're going to accomplish today is try to establish a baseline for those current response times, find benchmarks that we can use, and eventually get to the point where we have our EMS system evolve from a reactive to a proactive model, and thereby reducing those emergency department visits and providing better care at a lower cost. Now, a bookkeeping item. I know several of you saw that Valerie had put together and sent out some materials late last night. She's been working very hard at getting that. We had a conversation because I've heard from some of you that there was a concern about the timeliness of getting those materials, being able to read them, and have an opportunity to digest them prior to our meeting. So going forward, Valerie does have a plan. Valerie, go ahead and tell us what that's going to be.
Yeah, I apologize. I realize when you get documents at 10:45, 11, especially when we're sending several presentations, there were some hefty attachments that it takes time. We will, as we talk about a regular meeting schedule, which we'll talk about today, this will just become a regular packet item that you receive with your agenda packets. So your next meeting, especially since we have a cadence of Tuesday meetings, it'll easily fit into that schedule. So Hillary and I will work together to make sure that packets are included out at that date. I appreciate your patience as we've worked through the logistics of getting set up, but we will make sure that's the process moving forward.
All right, thank you, Val, for addressing that. All right, well, let's get started. Hillary, I think you have an overview for those follow-ups that we discussed at our first meeting.
Yes, so let me make sure, is my microphone on? Yes. So first of all, there was a request for materials, and I believe all of those that were requested, and I'm gonna look to you, Jared. Did you receive all of the background materials that you had requested before? You can just nod, you don't have to. I caught you with your mouth full. Okay, good. We also sent out a draft schedule, which will be the next agenda item we'll talk through, but that's important as we move forward. Val just touched on packets and what we're gonna do to ensure that we get the materials to you sooner rather than later, and work to the schedule that you all set. And we did not have any media requests. We had just one that was just a validation. Val, do you want to touch on that?
Yeah, we, Harriet Ramos with Star Telegram had reached out a couple of weeks ago doing a story on EMS. I think she reached out. I know I've talked with her. I believe she reached out to Mayor's office and also to MedStar. She was following up just on the transitional funding request. So I'll provide a response to her. So I'd anticipate that she's getting a story together to get printed here soon.
Okay. I received all of the hospital contacts information, and so I will be touching base independently with the representatives from each of the hospitals and bringing back a composite report to you at the next meeting of any overarching issues or any commonalities that I find before we engage them more specifically in the future. And the moving forward with our schedule, we are intending to bring financial reports regularly for review. Probably, I guess that's going to be once a month. I'm not sure if we have set which meetings. Okay, and so we'll be bringing those to you, and then of course providing them to you in advance. We will need to, after today's conversation, when we get to a point where we have sort of established our baseline response times as they exist today, we'll need to be looking at those reports probably monthly to ensure that we're not slipping or to see if we're making any improvements. And then obviously media reports as those come forward. So the next thing on our list is to talk about the meeting schedule, and I'm assuming everyone had an opportunity to look at it. It has drafted sort of the topics that we think we're going to cover. Now that we recognize we're really going to be shortened on our time, we're really looking at probably an hour and a half is most realistic. Some of the things that you saw initially initially thrown on will probably get shifted so that we can make sure we maximize our time. And today's schedule is going to be kind of meaty. You all saw the information that was provided, and we'll be going through that in detail. But did anyone have any concerns about the dates and times on the calendar that was presented, or are we clear to keep moving forward with that schedule? Go ahead, Val.
And I'll tell you, I really just captured kind of the Tuesdays that made sense. I mean, this is really all the Tuesdays. I tried to mark out holiday season, which is Thanksgiving and December, January, early in the month. I wasn't sure about any conferences, TML, or any of the kind of regular conferences that mayor and council attend. But this is really kind of the Tuesdays that are available to us, and if there are any that you want to remove from the calendar, we could make the adjustments. But I'd like to get this shared with City Secretary's office, and that way we can get these on calendars and get it posted.
Did anyone have?
Everyone okay with that?
Okay, so we'll pursue as it is now, and if something happens along the way and we need to push an agenda to a future date, we will do so. But this will hopefully allow us to get the level of information we're seeking, but also keep us on the timeline that's prescribed and within the confines of the time that we have. All righty. So then that moves us to some of the meatier part of this discussion. We're going to have some guests who join us, but in let me get to tab 3 in your neatly printed materials. We're going to look at service models. The purpose today is not to necessarily decide on any model, not to say, you know, this is where we're leaning or not. It's really to kind of get a broad understanding of the different types of models. And then we'll also look at some comparison cities to see what others are doing. Obviously, you're having a complete study of this done throughout this process, and so that will be helpful. But just to have some perspective. And so Chief Horton and Ken Simpson, I knew that. It took me just 1 second. I had to look at you. And I think is that it for our? Okay. So what we'll do is roll through these slides and just kind of hit the high points, but I'm going to ask either of these gentlemen to interject as, oh, go ahead, Val.
Sorry, we also have Captain David Saber.
Hi.
So if you want to maybe divide up at the microphones, that would be good.
There's another mic over here if anybody wants to come.
Okay.
Oh, yeah, there's the handheld as well. So we'll start going through just kind of these generally accepted models and the kind of pros and cons for each of them. And I would hope that my experts, who I'm calling you all today, will join in and give us any insights or thoughts that you have or answer any questions of the committee. So with that, we will just start clicking along. So there's no perfect EMS model. EMS models tend to be built for what the area, district, whoever needs. And so there are a number of different models that we'll look at today. And what we've also discovered as we've moved through this is that not every model that we look at is as cut and dry as what you see here. Some are kind of mixtures of them in some ways. And so this is kind of generally accepted, national information. So there's pros and cons of each. When a community is deciding on which model they choose, it's typically based on, their community's needs, which is patient care. How do we best serve the needs of our community? And there are various ways that they are overseen. There are various types of bodies. There's various types of organizations. And so we will go through these here in some detail, but basically you've got, the system is designed for clinical quality, service quality, economic efficiency, accountability, improvement, and resilience. And so those are kind of in general the key components of most systems. And obviously you all have a different system than some other large cities. It's unique to my experience. And so it was developed over time, and we'll get into the background of MedStar in a presentation here in just a moment. But this is, I'm just going to jump into the EMS system design should include, and it's all of these things that you see on the board. So, and this has probably changed somewhat since COVID. I think we're experiencing some unique needs and some different circumstances than we did before. But, all of these things are considerations when designing a system, and of course will be looked at as the consultant goes through trying to figure out what the right solution is for Fort Worth. So you have traditional EMS designed to focus on the delivery of emergency care, but currently it's part of the overall healthcare system. Non-emergency care at the scene. There are changes in the way that it is compensated, what people are using it for. Some systems do, like non-emergency transport. Some do on-scene care. Some do, hospital triage. There's any number of things that go into it, but EMS systems and how they perform, how they respond can affect the ultimate outcome of a patient. And so trying to be as efficient and as equitable as possible is important to this community satisfaction, but at the end of the day, a lot of it comes down to cost. And so what level of service can be afforded by a government that has competing, needs or desires, and what is the best level of service that can be achieved under whatever those circumstances are. So there are these service models we'll go through. So you have municipal third service, fire or police link service, charity, not-for-profit, private, for-profit service, public utility model, and hospital-based service. So the third service model is a third service. So you have police, fire, and now EMS in a city system. It's a standalone department of a city or county government, just like police or fire, and it's dedicated to this emergency ambulance service with EMS personnel. The traditionally staffed with civilian employees, like its public safety counterparts, completely owned, financed, and operated within the local government structure. The municipal EMS chief or director reports directly, typically, to the head of the municipal government, public safety director, or public health director. And it's often perceived by providers as favorable because it's dedicated to emergency ambulance service and appears to provide parity between EMS and its public safety peers rather than being buried necessarily in a fire service or other service. So I'm going to look at my panel here and ask, do y'all have anything to add to the information that's been on?
It's later in the presentation. But I would just
microphone.
Sorry. I would just say later in the presentation, the city of Austin uses this model. So of probably the 20 largest cities in the U.S., they're the only one that does a third city service like that. So that if you want to compare that to, look at Austin.
Yeah, and we'll look at that list that has the specific agencies that use these. But here's advantages and disadvantages. I'm going to give everybody just a minute to read this. But, being focused on as EMS being, an independent function where there is more attention paid to it versus it's part of the fire system is one of the advantages. And in this case, uses a civilian workforce. Anybody have questions for the experts related to?
Elizabeth?
Yeah, I do. So I'm looking at the list of advantages, and I don't necessarily see how it's an advantage. For example, it uses a civilian workforce. This lets the department offer wages that are competitive. I think that's a disservice to what we do here at the city because we definitely strive to offer competitive wages. So that's just one of the things that kind of jumps out here as we do this. And for me, as I read it, it feels like the language used here was to say these are all of the advantages, right? And we're pro-advantage. We're pro doing that, pro third party as I read this. It doesn't seem neutral to me. And I think it is imperative as we move forward in this process that when we're doing things like this, the advantages of disadvantages, that any bias or any preconceived notion be removed from that because what we need is a lot of facts. And let us do that because another thing, and I don't think you intentionally meant to say it, but when we talked about the cost, and us having competing interests. That's not something that I think we should be framing it that way. I think that the cost is the cost to provide the level of service that we need to keep people alive. And so, yes, there are always competing interests, but our priority here is to figure out what it takes and then take that to the public and let them know and let them ultimately decide. So I think words really matter in this situation. And I want to make sure that we're being neutral so that we're not skewed one way or the other.
And I think that we, in preparing this presentation and making sure that it was not biased, we really looked at sources out there that were unbiased academic resources, quite honestly, instead of just relying even on our local expertise, because when you do research out there, you can find some really, really biased stuff that I think that as you read through the advantages and disadvantages of all of the models, it's kind of in that same voice. But I really think that it does provide the pros and cons really in an open way. But I understand because it is hard to find information out there that isn't trying to push for one or the other. But I think you'll find that here they really do the bias and the advantages and disadvantages really equally for all of them. But I understand what you're saying, and our intent is to bring unbiased information here so mayor and council can have the information and facts to really determine what level of care and service we need here. And we understand that's the first priority.
And I should have said that this did not come from staff or any of the parties that were here. It came from a public document, a national document.
But it's a good context to keep in mind.
Yeah.
Yeah.
Anybody else with this one, or, okay, good. So then we have the fire-based EMS service. This, I think, is probably more common in, mid-sized cities, I would suspect. But it is that you have firefighter EMS personnel that are typically housed out of the same place and are on one or the other apparatus, just depending on the need. But they're cross-trained, so you have multi-role firefighters and first responders. And they are, there are two submodels within the fire-based EMS service. And so you have the dual role, so the personnel trained as both, and they may be assigned to one EMS function or fire function, depending on the day or the shift. And then you have single role systems where you have this EMS division or section where the personnel is assigned to EMS function, though they have been trained in the other, but they're more specifically assigned. I'll tell you that the city that I came from, everybody was trained in both, and it just depended on the day of the week which apparatus you were on. The focus is on the 911 patient populations and not necessarily that interfacility function. And emergency ambulance service over the last decade from other models into their fire departments has been a common trend. So this is, again, from that same text, the advantages and disadvantages. One of them is that you've got firehouses that are already located specifically to reach geographic areas of the city. Fire departments have a certain feel in a community as being, heroic, and people generally like them, which is a good thing. And management and being able to utilize some personnel for multiple management type roles, training, variety in duties, so that there's, some flexibility or some variety in the day-to-day, cross-trained personnel, on and on. And then the disadvantages, EMS call demand acts differently than fire call demand. Typically, it is a large percentage EMS and a smaller percentage fire calls. Fire departments historically deployed ambulances using a fixed neighborhood station model with 24-hour shifts, but there are high and low times during the day. So you may have overpopulation of personnel during non-peak hours. And then, sort of the same number of people during peak hours. And then, that's what that says. The 24-hour shifts, labor force organization, just like the fire department here with the 440 and agreements. And only serving patients who request care through the 911 system, and then having to have that partnership or that subset of the private providers who can do inner hospital or the transports from, say a nursing home that's non-emergency, but the patient needs to get to the hospital. So I'll stop there. Anything to add to these?
Chief Warden.
Well, and I'll just say, I mean, I don't want to belabor the point. Again, this is just to give everybody an overview of all the systems that are out there. But this was from a single journal article to present this. But we do understand that the city of Fort Worth is almost 1 million people now, that we would have to have peak demand units, and we're not just going to have them at every fire station. The fire department's traditionally built as a high reliability system to get geographically everywhere in the city, but we understand any kind of change in the EMS model would require different things. Within the Fitch and the Citygate reports, they talked about quick response vehicles, attack units, those kind of things for engine companies that are already too busy. So again, it's just an overview. But.
Yeah.
Go ahead.
So I guess maybe if someone can help me understand how the, making the fire service an attractive employer for many career EMS providers, how that's a disadvantage, because to me, would that not solve some of the high turnover rate that we'd see in our paramedics? With the utility models, like not just here with MedStar, it's others as well, the high turnover rate. If there is more attractive compensation and programs, we would see a lot less turnover. We'd see, I believe, a higher level of quality of care. So if you can help me understand why that is a disadvantage, and also the only serve patients who request care through 911 systems, because the way I see it, the transfers, should that not be a cost of doing business for those hospitals and those other ones who they're already collecting a ton of money from their patients anyways for what they're doing? So if they're transferring them and it's a non-emergency, they should have their own ambulance, the way I see it, and transferring their own patients, because that's part of their daily duties. If it's an emergency, obviously, sure. I mean, if this was a fire-based EMS, then fire could, handle that. But if it's just a basic transport, the priority 4, yeah. So I don't really see that as a disadvantage either, because that would be a cost savings too. So can you just explain really how those are disadvantages?
So when I read it, the labor force has long been heavily organized, was the part that gave less flexibility, meaning that there's collective bargaining or whatever those agreements are. I think that the 2 bullets underneath, well, the first bullet I think was kind of a yes, but. You know what I mean? I didn't
Gotcha.
read that one as a fully, but what I will say is that, like, if the city takes it on and the city has this collective bargaining situation and they are inserted into that, there is a negotiation that happens. It's not just, the city doesn't have complete control to say this is what we're going to pay.
Gotcha, okay.
You see it, yeah.
Yeah, I was going to say, I think it was just the structure of collective bargaining sometimes puts in constraints. But again, and I think in looking at, and really all the articles that talk about this, they try really hard to again, kind of be neutral in their stance. And as they were saying, just the complexities of labor, it was just that point that it does make it more competitive, that you could get people probably hired. They like maybe the terms of a bargaining agreement. They feel like they're more protected. It's just something as a city we just have to be mindful of.
Right, okay.
And then I think the last one was specifically that if there is a need for that transport of some sort and they don't utilize 911, then the city would have no idea. So, and does the patient know to call the hospital for non-emergency transport, or are they calling 911? You see what I'm saying? Like, there's a little bit of more gray in that system versus everything just goes through 911 and we do all of it.
And on the left side, it does say that cross-trained personnel have the lowest attrition rate in the industry. So I think, like what they said, it's the whole labor agreement and some of those kind of working through those. As far as the 911 transfers, Ken can probably answer it better. But traditionally, in your fire-based systems, they leave that to private providers, kind of a competitive marketplace. So THR has CareFlight, which does non-emergency transfers. So there would be a competitive marketplace that would take care of those non-emergency transfers. Fire-based could certainly take care of critical or emergency transports. As far as a public utility model, kind of what we have now, because that's a revenue generator, it's a closed system so that only MedStar can transfer the patients. And I think it's only about, something I read, like 5% of their total call volume or something along those lines, but that's a revenue generator for them. Whereas on a third city service or a fire-based side, we're not as interested in that piece of the revenue, so we leave it to the competitive marketplace to do the non-emergency transfers.
And if I could just also add, some of what, there is no perfect system, right? And like they said, everybody's going through very much the same struggles that we are currently. Some of the non-emergency stuff that they're talking about, what we're seeing in some of the larger metropolitan areas is some of these services, they can't keep up with the volume, so they may go out and assess a patient and call a private, or offer them a private provider, so they may access the system through 911. Typically, hospitals are not necessarily responsible for transporting patients and things like that. So that is left to the free market in some of the systems. What Chief Horton said is exactly correct. It's about 9% of our call volume is the interfacility transfers, 9. It makes up about 17% of the revenue. That's later on in the presentation also. But we use those costs to offset the 911 system. So if we didn't have those, it would mean that the 911 system would cost that much more money, basically. We use the private to help fund the public side of it on the 911 side.
And if I could note too, and I probably should have done a footnote, that many of the disadvantages are listed, but they're not things that can't be overcome. And so that was one of the things that they note, that some of the disadvantages referenced, they're not landmines necessarily or something that's an act of God to change. But it would just require some change. And so it's more listed just to provide a full perspective, but it's not necessarily a deal breaker.
Right?
Go ahead.
Oh, and stop me and tell me that it's another portion of the presentation if I'm asking soon, or if it's in there, but EMT versus paramedic. When we talk about EMS and the fire department, could you just kind of walk us through, because Charlie's on this committee, as simple as possible, what the difference between
No, I can do that
You didn't
quickly
hear
if
me.
that's all right.
You didn't even hear it. I got you so good.
That's complimenting you again.
Yeah, the difference between a paramedic and an
EMT.
EMT, and how they're deployed in fire departments versus how MedStar uses both and/or one or the other now to help us.
Okay, so quick down and dirty, EMT versus paramedic. Paramedic's known as a cardiac tech, basically. They're taught to read EKGs, that go look at your heart, provide cardiac medicines, things like that, some higher level skills. EMTs, they typically do basic life support skills. They'll do CPR. They can put some airways in to when you stop breathing, things like that. So what they do is important. It just they don't have the advanced training. The school is about 6 months, I think, for an EMT, 3 to 6 months for EMT versus 12 to 14 months for a paramedic. So the paramedic's a little bit higher level credentialed. As far as what we staff, the majority of what we staff today is ALS ambulances. We have integrated some BLS ambulances into the system. As Councilman Flores mentioned earlier, all of the 911 systems across the country, I've not heard of anybody jump up and say mine doesn't do that, are experiencing very high levels of very, very low acuity calls in the 911 system. So those calls would go to EMTs. They typically tend to be a little bit more prevalent and things like that. Again, EMT, when you have a cardiac arrest event where somebody's heart stops, the first steps of that are all BLS.
And BLS versus ALS.
Basic life support, so EMT care. ALS is advanced life support, typically paramedic care. And I'll let Chief Horton.
Well, and your staff, what level are they?
The majority of the ambulances that are in our system, I'd say 96% of them on a daily basis are ALS. They have a paramedic and an EMT on them. There's a percentage that is BLS, just so that you have an idea as far as what we bill and what insurance will pay for. They pay different levels for ALS and BLS. It's about 50-50. So about half the calls that we actually run and actually see, we actually do some sort of ALS service, even if it's just an evaluation. Does that help?
And then Chief Horton, you have?
We have 90 paramedics assigned to operations. We have about 120 in the department. Some of them are assigned to non-operations sections, but we have 90 in the department. In June, we started with 7 constant staffed ALS engines in outer areas of the city. where everybody has longer response times.
Do we have any EMTs or only paramedics?
So all 979 members are trained as an EMT. When we hire individuals, they all go through EMT training, then they go through their fire training, and they maintain at least the basic EMT certification throughout their career. So we have every provider on every fire truck is an EMT.
Thank you.
Good questions. Proceed.
All right. Okay, not-for-profit-based EMS systems. These exist. They vary greatly from all volunteer to some volunteer to paid to career. Some have evolved starting as volunteer departments and then created more full-time or permanent to meet growing demands. They can be fully emergency. They have independent governance with a board of community leaders or stakeholders. Again, they can be different models. And as with the for-profit, the assets are owned and controlled by the board or whoever the oversight group is. And the independent structure may result in being lumped in with private for-profit companies. But the generated revenue would be directed back to the services provided. And
Before we leave that slide, either yourself, Chief Horton, or Ken, comment how prevalent, nonprofit-based EMS services are nationwide, generally.
They're a minority, I would say. CareFlight's a 501c3. They're a nonprofit, hospital-owned. There aren't a ton of them, and there's even less volunteer services around.
Right. For large municipal governments, I'm not aware of any that run this kind of system.
All right, thank you.
Can I follow that up? Do we have any examples of company names that we could look up that are nonprofit-based?
Well, like he said, CareFlight, operating their helicopter and their ground transport
But-
ambulances. And I
okay.
think they have a few contracts with very small cities.
Outside of CareFlight, is there anybody else?
I'd have to look.
We can certainly look and
we'll
try and
provide
find
that
some for
later.
you.
I'll write that down.
Right.
Go ahead, Hillary.
And to the advantages and disadvantages, again, depending on which seat you're in, these may sound like advantages or disadvantages or neither or, but they're often self-sufficient, minimally subsidized, just depending on the mix of the agency or the organization, and depending on their mission. They can provide both emergency and non-emergency with, kind of diversifying their payer mix. And then depending on how they are formed, they can extend beyond geographical boundaries, which, MedStar does that already. So, but there are some advantages there. And then the disadvantages, if it's a volunteer board or a board, your leadership changes over time. Accountability can be an issue as a nonprofit. You don't necessarily have the same requirements for public record as a government would, or a governing board, public government governing board. If there is a mix of volunteers versus not, there could be some issues with the management and personnel management within those systems. So again, this I don't think is a super common system. I haven't experienced
LifeNet is another one.
LifeFlight,
LifeNet,
LifeNet.
they serve Texarkana. But you're right, it's not very
Yeah,
common.
no. And both of those systems more like helicopter based?
I'm not familiar with LifeNet.
LifeNet does, I think they have helicopters, but they do a fair amount of ground
They do
also.
ground too,
Yes,
okay.
ma'am.
It's a mixture. Anything else on this one? All right, private for-profit. Get to that in my page.
Oh, wait, before we leave this topic, I
yes.
did have one question that came to mind, either Ken or Chief Horton. For NFPs, these nonprofit models, is telemedicine more widely used in that model than, say, others?
No, sir, I don't think so. If I had to just guessing, I would say you probably see telemedicine a little bit more with hospital-based models, which we'll get to in a few slides.
Okay.
But I don't think any of the models, you're honestly likely to see a substantial increase or decrease of telemedicine use.
Okay, thank you.
This one, I do think, in our example cities, there's at least one, there may be two, examples of, but basically, the city, contracts it out to some private, company. And so those contracts can be created in a way that services whatever the needs are, so emergency, non-emergency. And they are performance-based, so they would come up for some sort of review. There would be expectations set out in the contract to be met, and penalties if they were not. Management and oversight of clinical care, day-to-day operations, assets, and capitalization, all accomplished in the private sector. And the level of support of the local government is negotiated. And so we want this level of service, and this is what they say it costs, and we work that out through a contract. So advantages, disadvantages, these can be tied really directly to day-to-day operations and service expectations. Part of what we're doing here is figuring out what service level we are currently providing, and if that is acceptable, not acceptable, what we think is most important. And that would be negotiated through these contracts. Managing the organization, but the company owns the assets, so the city doesn't own the assets of the equipment, but the company would price that into the contract and deal with whatever issues arise from that. Performance-based contracting, communities have clear scorecards, we touched on that, and in most cases be heavily engaged in the non-emergency market as well, which Ken sort of touched on. It helps sort of offset some of the costs of the emergency market, which may or may not be paying for the services rendered. Disadvantages, lack of accountability and transparency. So yes, they would be providing reports to the governing entity, the city, whoever, but their typical records aren't held to the same public, open standards as a city. Unregulated competition. If the outside provider, just for whatever reason, just decided to go out of business or sell or whatever, you don't have necessarily the most control there. And then private for-profit companies can be less attractive for field providers because the wages may not be in keeping with what governments are paying and or the expectations in a corporate environment versus a government environment may be different or less desirable. Anything on this page?
Anyone? Looks like not.
Okay. Hospital-based EMS. We touched on this just a teeny bit, but basically these are run by a local hospital. Works well if you've got a big hospital in your city, but when you don't, maybe not quite as advantageous. You all have the luck of having multiple. But the EMS service is provided directly by the hospital as a standalone entity controlled by the hospital. Clinical administrative billing resources drawn from parent entity, and they get to choose what services they offer, whether emergency, non-emergency, and it would be up to the hospital. So the advantages, obviously hospitals are parts of communities, and so having that community trust or respect can be useful, can be more stable than maybe the contracted out services, because a hospital has, kind of a longer lifespan typically than maybe some companies that may bid on a contract. Continuum of care, so obviously if the people who are treating the patient in the, emergency and taking them to the hospital, they're going to understand what the hospital is going to do in their systems and all of that pretty inherently. Continuing education, being part of a hospital may mean higher wages and potential career development for potential personnel. But it's not uncommon for them to function in somewhat isolation. And again, you have 5 different hospitals that service your area. And so what would the mix be in a situation like this? Could be somewhat confusing to the public and or complicated. Go ahead.
I was just I'm not paid by CareFlight. I'm not advocating for CareFlight, but just to that point, CareFlight is actually owned by all of the hospitals in this area except for, I believe, Medical City. So JPS has an ownership stake in them. THR, Baylor, Scott and White, all have ownership stakes in CareFlight. My understanding is that THR owns 51%. So that's kind of how they address that. There's also some Dallas hospitals like Parkland that are in Methodist that are owners in it as well.
And I think these are more common, like, I believe the first slide said in rural areas where you don't have the infrastructure, where you're not gonna have volunteers that can run an ambulance 24 hours a day. There's not paid fire service personnel, so the local hospital takes over the ambulance piece. They've got a couple ambulances that serve that rural area.
Yeah. Waco did it for a while with Baylor, Scott and White. Excuse me.
Yeah, we have, in the city that I live in, Temple, there is, Scott and White Hospital is headquartered there, and so they have their service, but then there are other private services, but the city's not, they don't do the EMS service there. The EMS department, where is it structured within a hospital system? How much priority does it get? How much, what is the service level that is expected or required? Revenue recovery, hospitals have their own billing services and can do that, but you know, if bills aren't being collected, payments not being made, then what does a hospital have to decide financially about the service rendered? And then, you know, the bills to the community might be larger based on whatever the hospital's charges for service are. And hospital-based services have to ensure local laws, hospital policies are followed in regard to patient destinations. So what that means is, if I'm hospital X and I'm picking up the patient and the patient really needs to go to a different hospital than my hospital, but I'm going to take them to my hospital because we're rendering the service. So there can be some of that maneuvering about where do they go and what's the most appropriate care. Whereas with a city or some other model, there might not be quite the same tie to, you know, this patient goes to my level 2 trauma center when they really needed to go to a level 1. I don't know. Anything on this one? Any questions on this one? Okay. All right, public utility model. Strictly defined business structure with a public agency providing oversight, but day-to-day services and management historically contracted to an ambulance provider through a competitive performance-based bid process. Most public utility models self-operated, contracted providers have sometimes created more employee turnover due to instability. System structures created with checks and balances in mind to create clinical emphasis and an independent medical director accountable to the board of directors and operational emphasis accountable to the board of directors and financial efficiency accountable to the board of directors. So this has clearly this board structure that is expected to hold accountable the provision of service. And, you know, local officials have more input or say in these types of models typically. You jump in here anytime you want, anytime you want.
Yes.
Because ours is basically.
Yeah, so MedStar is a public utility model. It's, you know, as she said, the majority of public utility models have gone to self-operated. The challenge with using contractors is there's so much information that goes into that bidding process that when they build out their financial pro formas and their estimated performance delivery and things like that, there's a lot of margin for error. So they typically weren't seeing the return. It's like everything else, right? When you write it down on paper, it's supposed to work. When it goes into practice, it doesn't always work as effectively as it could. Sunstar EMS in Pinellas County, Florida still uses a contractor-based model. They are a public utility model. They are a taxing entity. So they receive tax dollars, and that's part of how they run their system. And they run it as a system, and it seems to work pretty well in that case. So, you know, so again, one of the big hallmarks with public utility model is independent medical direction and separate oversight, so that me as the operator of the organization, I can't tell the medical director, no, we're not going to buy that thing that's a big life-saving, statistically shown to improve life because we can't afford it. They have the opportunity to take that to the board, have the discussion. And the board has the opportunity to say, yes, we need to find a way to do that, or whatever's required along those lines. There's also a lot of quality assurance and quality improvement activities that go into that. And then likewise with the financial reporting and accountability, as well as operational reporting and accountability to the board is, we'll get into this a little bit, but our board is made up of 9 members, 5 of which belong to the Fort Worth Fire Department. The City of Fort Worth. One of them is the fire chief. And the other 4 are from suburban cities, 2 physicians, and another first responder advisory board member. So that's how we try to achieve the input from the system and the system stakeholders. So.
Okay, go.
All right, so that was kind of the quick rundown on the different types of systems, but now we wanted to show you some examples of those that exist locally, statewide, and then some of the cities that might be comparable nationally. So the first ones we'll look at are the top 5 in the DFW Metroplex. And you've got Dallas running a fire-based system, Fort Worth, obviously public utility model. Arlington is private, and then Plano and Irving, both fire-based. And of course, the populations, you being closest to the Dallas system, comes into play, but you can see that a city about half your size is using a private model as well. So now if we look at the top 10 cities in Texas, you can see Houston, San Antonio, Dallas, all fire-based. Austin, we mentioned earlier, is running that 3rd city service. And then Fort Worth, El Paso, fire-based, Arlington, again, private, Corpus Christi and Plano, both fire-based, and Lubbock, private. So obviously in Texas, the fire-based seems to be a more common system, but there's definitely a mix in those populations. Oh, yes, please.
Have we, since it looks like Charlotte is really the only other comparable city around the same size that's using the utility model, have they done any recent studies of their own to see how they're currently, because I know obviously this, what we got going on with MedStar is not unique to just MedStar. It's
Right.
across the board. So if we looked at Charlotte as well, or even really Indianapolis as well, and 'cause, I mean, they're pretty similar. So I'm sure they're going through the same things. So can we look at them as well and see what
Yep.
they're doing?
That would in part, and that's a good question, Charlie, that would in part have to deal also with how long, the current systems have been in practice, right? I think I had asked staff if we had that data. Do we have that, Val?
We will get that to the committee. We need to get it just added on to this data set to show how long that system has been in place. I agree that would be useful. And we can follow up with some of the case studies from those cities to let you know what's going on with their agency from just operations and financials.
And then again, I mean, we look at this and we can compare all we want and say, oh, everybody's fire-based, but Fort Worth is unique. They all are. And so just kind of getting an idea of what's more common, I think, is helpful. But obviously, there's going to be a much more in-depth study that determines what is the most feasible or what mix. I mean, it could be that it's a mix of systems. And then, of course, the service MedStar is providing now reaches beyond the bounds of just Fort Worth. And so considering those other stakeholders will be important to any change that's made.
On that too, the, where it says 3 have a hybrid model, I'm assuming that's a mix. Are those, that's not on this list, is it?
They are.
Because I don't see either.
I was just going to.
Yeah, the first one, New York, says fire-based and hospital. San Diego, fire-based and private.
Okay, so those
And then
are
San Jose,
hybrid.
fire-based and private. So I don't know, is that because they're doing the non-emergency stuff? Do you know?
No, well, New York is so big, like, they have multiple hospitals and private providers that are in there providing additional service. What you're seeing in California is that the governmental-based providers get a higher reimbursement from California's Medicaid system. And so what they're doing is the fire departments are partnering with private providers, and the private providers are supplementing the service. The municipalities are actually billing without getting too far into the weeds. It's a financial arrangement that comes out, because literally, like, a private provider would get $200 or $300 for Medicaid transport. If it's billed, if the same transport with the same staff is billed through the municipality, they're getting $1,000. Now, the federal government may be taking a look at that, but that's why you're seeing a big push to that in a lot of areas in California. It's certainly something that is being talked about currently, and that's why you see those specific California models like that. they're bidding on these contracts together.
Dollars? Do you?
I was just going to call out, we noticed just a correction we need to make on the slides. In the reporting structure for City of Fort Worth, it has reporting up to, and this is the medical director reporting to the Emergency Physicians Board. We just need to better define that because they report up through that board to the MedStar board. So we'll clarify that. But this reporting structure was meant for the medical director piece, so we'll clean that piece up.
Thanks for pointing that out.
And I'm jumping ahead a little bit, but on another column I think would be helpful is the dispatch models for each one of
Okay.
these and how that differs and how that impacts the response times and how each, if it's fire-based and private, how did they decide who responds?
That's a great point, and that is on our list. The dispatch is on our list for next meeting.
Correct.
And so adding that into this list, I think would be helpful.
The dispatch times are, or the dispatch
No,
method?
the dispatch
models.
models.
Okay,
The dispatch times are today.
okay, gotcha.
Okay. Okay, and so in summary, the hallmarks of a good EMS system, we kind of started with this, but basically, number one is the system holds the service accountable. It establishes an independent oversight entity of some sort, whatever the right model is there, accounts for all service costs and determines what is a service to the community that the city is willing to provide, at no cost or at reduced cost or whatever that is. Requires system features that ensure economic efficiency and ensure long-term high-performance service. So not, we're just gonna fix it for right here and this is gonna work for 2 years, but for the long term, the less disruption in the service, the better for the public. So just in summary and in conclusion, does anyone have any issue with any of these as being part of the standard that we will be looking at moving forward for a good EMS system? And is there anything that you think is missing?
I don't have anything right off. I don't know if any of the board members might have any suggestions.
And as Hillary mentioned earlier, this all came from that single article, so if we want to add to this or adjust this in the future, we can make amendments to it. It's not we're not going to make you sign in ink today, but.
I mean, the one thing that is not in blue, it's sort of buried in the rest of it is the patient care, high level of, I feel like that maybe is missing from the forefront. But that's just me speaking and throwing it out to the committee if that's something that's important.
Yeah, I think they should probably be brought to a blue box and make sure that's like probably hallmark number one.
Number
Because
one.
you could have everything that's accountable, it's great service cost,
Yep.
but if it's not providing, basic care or what's expected of everyone in the city, at the cost we can provide it, then
Yeah.
it's all moot, so.
Does everyone feel the same?
Yeah, that's a good
Okay,
point.
then we'll make that for moving forward. Okay, moving right along to section 4. I'm going to turn this over to Ken Simpson now to give us an overview here. I'm going to give you this. Oops. Clicker, and he's going to take us through kind of high levels.
Oh, you got it? Yes. Good deal. All right. I am Ken Simpson. I'm the CEO for MedStar, as I think everybody here knows. I'm going to quickly walk you through, although my presentation starts with like in 1985, I'll go very quickly through this for you to give you a little bit of background and history on MedStar, kind of where we came from, where we are, a little bit about us, a little bit of kind of what got us here. So in 1985, the city of Fort Worth was served by 7 different ambulance services. They were struggling. Some of them didn't have air conditioning, some of them didn't have oxygen, things like that. The service was not very good. There was a committee that had been put together with the city of Arlington, the city of Fort Worth, and Tarrant County, actually even before this, to study the possibility of a county-based EMS service or a county-wide EMS service. It got to the point where Fort Worth realized that, they were going to have to take steps to do something. And they started the Fort Worth Ambulance Authority, basically, under Assistant City Manager Bob Terrell. Under Bob Terrell, and the mayor at the time was Bob Bolin. And so Assistant City Manager Bob Terrell is in that top picture there. The picture in the middle is kind of from opening day in 1986. And then the bottom picture's from us opening the new facility. I didn't put any pictures of the old facility in here because it's really nothing that you want to see anyway. It was not very attractive. So when they started this system, basically to create it, the assistant city manager reached out to the medical community. Dr. John Jesbray, who's passed in the last few years, and Dr. Steve Martin were integral in kind of setting it up. They wanted the system to have a good clinical focus, and they wanted to build out and make sure that that was a central theme to the EMS service. As you said, patient care has to be a main crux of that. So they built, as part of this system, the Emergency Physicians Advisory Board. That advisory board is made up of the medical director for the emergency room of every hospital in the service area and specialties from Tarrant County Medical Society as well. They have 2 seats on our board today. So, and then the remainder was made up of city council members. Again, this was known as the Fort Worth Ambulance Authority initially because it only served Fort Worth. It started contracting with some of the smaller cities shortly after its inception. And in the first year operation, they ran a whole 39,000 calls. We do that in about less than 3 months today. So the first interlocal was actually written in 1988. This was done because more of the suburban cities became interested in this public utility model and asked if they could join it as well. Again, at that time, it was operated by a contractor. That means the contractor actually provided the ambulance service. The authority kind of managed the day-to-day and the contract oversight. The Emergency Physicians Advisory Board and the medical director managed the clinical care. When they created this first interlocal, they added a seat for the suburban city representatives, and the EPAB continued to have a seat on that board as well. In 2017, we restated the interlocal agreement. And the name was also changed from Fort Worth Ambulance Authority to Area Ambulance Authority at the time. So in 2017, we restated the interlocal. We created a first responder advisory board that's made up of either the fire chief or the police chief, whoever's responsible for providing first response in the 911 system. The Fort Worth Fire Chief was added to the board as a non-voting ex officio member. An additional FRAB representative was appointed to the board as a non-voting ex officio member. The medical director and chief executive officers were also non-voting ex officio. It outlined the performance expectations and created an EMS system performance committee to set response time and performance goals, not just response time goals, but actual clinical performance goals as well. That board is made up of first responder and system stakeholders from the community to help set those standards. In 2020, it was amended and made the FRAB members, voting members, added an additional Emergency Physicians Advisory Board member who was voting at the time. And, whoops, sorry. I guess this is a touch screen. And added an additional Emergency Physicians Advisory Board member. During this time in about 2005, 2006, for the reasons that I talked about earlier, MedStar and the board decided to utilize a self-operated model. So we stopped using contractors and we started providing the EMS services ourselves. We saw higher turnover than what we wanted to see. Weren't getting the performance we expected. Ran into some issues that we thought would be better served by bringing it in-house, which they did in 2006. So over the last basically 14 years, in 2002, the dispatch center became accredited by the International Academy of Dispatch Centers. That is an ongoing accreditation that requires quality assurance as far as when the calls come in. We've talked briefly with the mayor and council before about triaging calls and having a methodology by which we triage those calls. We've talked about the relatively small percentage of really time-sensitive medical illnesses that come in and being able to parse those out so that we can make sure that we get as many resources as possible to those where time really makes a difference. And some of the others we can send different resources to. This is one of the ways that we're able to do that. We've also been accredited by CAS, basically, which is known as the gold standard in EMS. We've been CAS accredited since 2009 as well. Nationally recognized for innovative EMS since 2009, 13, and 16. We've done some things like nurse triage. So some of those low acuity calls that we've talked about, when they come in, they might get sent to a nurse. And the nurse would actually go through and work to try to disposition that patient without sending an ambulance or a resource to them. We get actually a fair amount of calls for prescription refills and things like that. So we were able to intervene with some of those instances. Likewise, mobile integrated healthcare to address some of the folks. We've had people that call 911 more than once a day, believe it or not. And so we have a team of mobile integrated health professionals, very similar to the fire department's HOC team in the homeless community, that go out and intervene with those folks, because a lot of times there's social issues that are going on. These folks also provide air conditioners and things like that to needy families that obviously in the summertime you want to make sure that you have air conditioning in your house. And so it's been beneficial from that standpoint, trying to be a little bit more proactive about managing the call volume and that kind of stuff. In this fiscal year, our call volume is anticipated to be about 191,000 calls, which is a pretty large increase, although it's been almost 40 years from the original 39,000 calls that we started with.
And Ken, I'm sorry, can you go back, just because I want to make sure if, as people are watching and following the presentation, the bullet point on operating without local tax dollars from 2010, the lowest cost municipal provider in Texas for the last 7 years. I think that really sort of sets up some of the conversations we'll be having later on in this presentation and in future meetings as we look at MedStar and their financials. So I just think that particular bullet point, just to add some perspective to that, we'll be talking more about that. And I think that, MedStar has gone without tax dollars and subsidy, but I think that it's led us into the conversations that we're having today. So just, again, wanted to just wrap some context around that particular bullet point.
Yeah, we received, thank you, Val, somehow missed that altogether. In 2008, 2009, tax subsidy stopped. In that year, it was about $3.2 million. We actually participate in cost reporting. Similar to the program, although it doesn't pay as well, that I was talking about in California, they require cost reports. And so as do they for any municipal EMS provider that wants to participate in that program. For the last 7 years, we have been the lowest cost provider in the state of Texas as far as that goes. We have also, over the last few years, contributed to adding capital resources and things like that. The programs that I talk about, like nurse triage, and those sorts of things, they're great programs. They help a small number of people. The challenge with those programs is there is no revenue source, and when you're trying to provide service, nurses like to get paid and things like that. So you've got to fund that in some way. We partnered with hospitals to help fund that for a period of time. Some of the other programs that we use, we've partnered to help fund, and we've actually sold some of those services to insurance companies because of the outcomes that we've produced out of those. And those, again, help cover some of the costs of we call them high utilizer groups instead of system abusers. But the folks that call 911, more often than not, the challenge we've run into is, we knew that the expense and revenue lines were going to cross. We started talking with our board about that back in 2018, 2019. And we did a rate increase that helped with about $3 million, and COVID came through. Really increased the expenses associated with ambulance purchases, medical supplies, things like that. People got out of the industry. Labor rates went up significantly. And so basically from that time, from about 2020 on, we've been utilizing our reserves to help purchase capital. So our operating costs are typically covered. And just a really quick, the way that we work that is Municipal government typically gets bonds to cover capital. We build up reserves, and we use those reserves to purchase the capital, and then we pay ourselves back through a depreciation schedule, basically. And what we've run into is we're taking in enough to cover our day-to-day expenses, but as far as being able to replenish those capital accounts as quickly as we need to, we haven't been able to for the last few years. So that's where we are. We're upside down. On a year-to-year basis, we've been spending $3 to $4 to $6 million a year, excuse me, on capital expenses.
Ken, I think
Yes,
that's a
sir.
question here. Go ahead, Jared.
It might actually be a question for fire. Excuse me.
Chief Horton, can you come to the podium?
Earlier, y'all mentioned that fire provides ALS to help the system stand up. Do you have a dollar amount for that?
So it's negotiated in the contract. It's the paramedics, just for the paramedic certification, they get a small stipend each month to account for that. So that would roughly be, I'd have to do the math in my head. We can get you those numbers. And
That'd
then
be good.
for our constant staff trucks, they did negotiate in this last contract a higher incentive to be on there every single day to meet that. It is a whole system. So in some of the studies with Citygate and Fitch, they talked about essentially what we want to do is get that ALS provider to somebody that's having that critical emergency as quickly as possible. So that's why we started using those trucks to offset some of that for them. And depending on where all this goes, you know, it's going to shift from either we put more ambulances on the street or we provide more fire first responders at the ALS level to balance the needs across the city.
Right, thank you for that. I bring that up because I think it's important on that fourth bullet about operating without local tax dollars, that we are in fact subsidizing it with services. And there's a real dollar amount to it, although it's not going through the budgeting and accounting for MedStar. It's helping supplement a system that isn't hitting the performance goals. And so I think that dollar amount is important because I think we need to adjust that fourth bullet about operating without local tax dollars because we are in fact spending tax dollars for first response.
And we can get you the exact dollar amount, because that's something that came out, maybe it was discussed before Citygate, but I know Citygate called it out that we needed to expand paramedic coverage to have equity to all of our communities. And like Ken had stated, there were just areas on the outskirts that they couldn't get to. But I think it was, did we put in 6 or 7 paramedic
We did 7
engines?
initially.
7 stations.
7 this year, so we can get you the cost of what those 7 were. Because the fire department worked closely with the Fort Worth lab to formulate that budget.
Thank you for that. I think that's important context because as we continue to grow as a
And
city.
we already had the fourth person there, so we just displaced that person with a higher advanced level trained individual so that we don't have the personnel costs. We just have a little bit of incentive pay for certification.
Right, and I think that's important to know because as we grow as a system, and even the Fitch study talks about it, we're going to have to expand the level of that first response since we are providing a first response. There's also a 2008 study, I believe, from Fitch. No, it was, I'm sorry, y'all provided in the report.
You're right, it's 2008.
Yeah, but the 2021 Fitch Burleson study, it was a similar case, right, where their fire was providing ALS services and then MedStar was providing additional coverage for the transports, for emergency transports. So I just want to put context again that there is a tax subsidy happening, although it's not directly going through MedStar.
No, we'll get that information, because I understand it, because, yeah, we should capture all of those costs, even if it's not direct support, it's kind of an indirect support, so we can call that out. And I did want to note, we did include the city of Burleson's report, and that jurisdiction has offered any support we need, or if we need the chief to come here and talk about their experience or their report, they're willing to do so.
All right, proceed, Ken.
So, and there's a timeline here as well. The basic idea behind this is that one of the requirements of entering the interlocal and working through this relationship is the member cities had to agree to provide first response for the calls that they could make a determination on what calls they went to. We have asked that they go to those high priority calls and have left it up to the cities as far as what other calls that they want to go on to. Typically the fire chiefs and other chiefs, but from that standpoint, we've tried to run it more more like a system rather than a segmented area. So kind of our financial assets was one of the other requests that I got through this. The interlocal also required us to maintain 3 months of operating expenses. From time to time, anecdotally, you'll hear this referred to as reserves. These are not reserves. These are our operating accounts. That's an important distinction because they're not in a savings account somewhere necessarily that we don't touch. We pay payroll out of these. We buy capital out of these. We pay for month-to-month bills out of these. So basically that 3 months is just over $15 million is what that total is that we have to keep on hand currently. We have a little over 23 million on hand, and we've got outstanding loans of just over $13 million. As far as capital assets go, we have a main deployment center there at 2900 Altamere, where the majority of our ambulances are deployed from. We have a north deployment center that has 14 additional ambulances that come out of that. It's up by Medical City Alliance. We have a backup communications facility at Grove Street near Berry. We have 77 ambulances, 24 single response vehicles, and then 3 UTVs. And we also have an ambus that's we maintain essentially for the state. It's also asked to kind of put our 5-year projection of capital into this, so you have that. I won't belabor that. Obviously, you all have dealt with budgets for a long time. You know this is fluid and flexible. So we anticipate, in all likelihood, it'll change from year to year. Next year, we're anticipating spending about $2.7 million, mostly in remounting ambulances and that sort of stuff, and replacing support vehicles. We put a lot of miles on these vehicles. Rather than running 24-hour shifts, we run 10, 12, 13-hour shifts, basically because the utilization is so high. Our folks are typically operating 70 to 90% of their shifts. They're on a call of some sort, either transporting at the hospital, basically taking care of the patients in some shape, form, or fashion. And so obviously that's not practical to do on a 24 or 48-hour shift. The other thing is we put a lot of miles on the ambulances because of this. So the capital refresh is very important with that. Yes, sir.
One quick question. Seeing the capital plan, how do y'all finance the capital from year to year? Is it cash or loans? I know in the past slide you showed how much y'all have outstanding in loans. How does that work?
Historically, before COVID, we typically tried to cover it with cash. We've gone through a period where we actually had to, so remounting ambulances, just really quick, remounting ambulances, take the box off, refresh the box, paint it, whatever needs to be done, and put it on a brand new chassis. That's about half the cost of a new ambulance. Our fleet had to be entirely replaced, so those capital costs were about double what they've been historically. So we ended up financing several years of that, which contributed to that. Going forward, we do not anticipate borrowing any additional dollars. Those obviously loans come with financial covenants, and one of the things we have to demonstrate is we're bringing in about 110% of our loan expenses above and beyond what's required. And so we want to make sure we continue to hit those loan covenants and things like that. So
that makes sense. Thank you.
Yes, sir. Our system structure is outlined here. To be honest, the dotted lines from the advisory boards were supposed to go to the board of directors. I'm not very good in making shapes, so I apologize. They don't technically report to the member cities because you haven't seen the advisory boards all show up here typically. But anyway, it's structured with the member cities at the top. As I mentioned, there's a 9-member board of directors. 5 of those members are City of Fort Worth representatives. 2 of them are for the Emergency Physicians Advisory Board. 2 of them are one additional is from the First Responder Advisory Board. And then we have a suburban city representative also. The idea is, again, from the Emergency Physicians Advisory Board, we get a lot of insight from area hospitals and things like that on protocol and medical care and whatnot. So that subject matter expertise is basically what we look for. We thought this represented kind of that system approach a little bit better, which is why it's structured the way that it is. And then you see the 3 levels that report up to the board of directors, again, for that medical independence and operational independence. In our head counts there, we currently have about 478 full-time employees and 53 part-time employees, and another new hire class that starts on Monday. So this area is growing exponentially, and so we've been adding a lot of people, adding unit hours and things like that as we've gone along. So we're always essentially hiring and putting folks on. Our turnover rate is typically at or below what healthcare's is. It is not, as somebody mentioned earlier, it is not the 1% or whatever that fire departments is, but it is on par with what the healthcare community is and typically lower than what private providers are.
Is that 20 or 25%?
20 to 25%, it varies by year. And honestly, I can't right off remember exactly what it is.
Thank you.
Question on that.
Go ahead.
Ken, is there a breakout? I don't think it's in here. It might be in one of the, I think I've already, maybe I have seen it, but a breakout of the Office of the Medical Director? Because there's 14 in there. Is there a way we can get a breakout of that?
Who they are exactly? I can get that for you. There is a org chart on here in one of the next slides.
Yeah, like an org chart and the costs associated with that as well, since it's
Yeah, so
such a
it's,
large office.
in total, the Office of the Medical Director's budget is about $2.2 million, which our total budget is about $60 million. So, so it's a small percentage of that total budget, but like you said, there are about 14 folks on there, and then there's 2 associate medical directors that are contracted employees. So. Our service deployment model is a demand-based deployment model. This is just kind of a graphic showing essentially what the average call demand looks like on a daily basis. We try to match our staffing to this. Obviously, we don't match it exactly to this. We try to utilize 2 standard deviations above it. And again, that's why our schedules are a little bit different from 8, 10, 12, and 13-hour days to try to cover that demand a little bit better and make sure that the system runs a little bit more efficiently than what it would otherwise. And as we move through this, we're often asked about the number of ambulances. On average, at peak, we see around 59 ambulances. Sometimes it's a little bit more than that. Sometimes it's a little bit less. We have 3 field supervisors at peak, and about 4 o'clock in the morning, our minimum is normally around 23 ambulances that are available and 2 supervisors. I think most of you all have kind of been through the little MedStar 101 that we do with the heat map. The little flags are posting locations, and our computer-aided dispatch system essentially selects where to move the ambulances in response to typical call demand. And we try to compensate also so that it doesn't just go on demand to try to cover some of the geography, and that our lower level posts, we try to force ambulances out to the further areas to make sure that that geography is covered as well.
A question on that real quick. Hey, Ken, are these broken out by, is this all priority 1 through 4, all priority, all calls, or is there?
This,
the service deployment.
that's all calls.
It's all calls?
Yes, sir.
Okay. Do you by chance have something like this that's for like priority 1 calls by chance? This shows like the level of those, and if there's a higher.
Oh, I'm sure, yes. I can slice it any way. I can't slice it any way you want. I know people.
Right.
There is another way of looking at that too, maybe not this bar graph format, but in the response time discussion. Now, we were just chatting about this right now. Given the time that we're at, we're nearly at 1:30. You know, we're not going to be able to do justice to the discussion of response time. So that's going to be a topic for the next meeting. Okay, so we're just going to go ahead and finish up with you, Ken, today.
Okay. But yes, we can slice it up any way we want. We've also invested in some modeling software that they're actually using in London, and all different models, fire department, but all the models you heard about earlier. And it essentially goes by historical call information. And so is you say, hey, I want an 8-minute response time. It can model anything that we want, basically, essentially off of historical volume, and we can build in an anticipated call demand on top of that. And it'll run those and tell you what kind of resources you need. It's very, very scientific, and as we go through this exercise, and even with the consultants, they've offered as a kind of independent third party if that's needed. I've got folks that can run the software, but I understand, like, we're MedStar, and I know why the committee's here. So the organization is volunteered to step up if that's something that the committee was interested in, as you guys have more of the conversations around response times. You asked a little bit about the medical director's office. the medical director's office provides, and the medical director provides oversight for the entire system. It was designed that way for continuity of care, ease of transfer between patients, that kind of stuff. The medical director is responsible both under state law and the interlocal for providing the medical direction, oversight, and quality assurance for the 911 system and the interfacility system here in the service area. So they go through and they credential all of the providers, the EMTs and the paramedics, both with the MedStar system and the first response agencies. They do quality assurance on, typically it's the higher acuity calls. They have a self-report system set up where if you have questions, or an outcome system also, if you have questions about, hey, how did my patient do? We have really good relationships with the hospitals where we can reach out and find out how the patient actually did. And they'll go through and I've seen them do it on the weekends for, unfortunately, a pediatric arrest. They came in on their off days, met with the crew, really walked through what was needed. They've done it with the first responders before. Again, they try to take a very systematic approach with this to make, because that's the best way to deliver patient care, frankly. So.
Can I ask a quick question on that? When you say, when you say first responders, are you talking about fire?
In Fort Worth, I'm talking about, well, fire and I think the SWAT folks on the PD side are also, well, they're not, yes, mostly fire.
Okay, so they're able to, y'all are both able to share information back and forth between the medical director's office?
Yes, and we operate off of the same set of protocols, so there's not any difference in how care should be addressed, things like that. They offer continuing education opportunities. The Office of the Medical Director does to both first response and the MedStar side as well.
Okay.
So again, that's the idea is that everybody's sort of operating off the same sheet of music when we come to take care of patients and have been through the same training.
And a follow-up question to that, does that actually happen? I know that's the idea and but does that, in practice, does that actually work?
So the protocols are definitely there. They typically try to, like, we go to a cadaver lab once a year typically, and we normally train collectively with that. Our continuing education classes are open to the first response agencies. We typically don't get a lot of first responders in that. That's one of the things that as we work through this, and we've talked a little bit, we need to make sure expectations are ironed out with that, because although there are 14 people, there are 15 cities today in this system, and if the expectation is to do quarterly, 2-hour-long continuing education classes for every first response agency in the system, 14 people is not enough for that. But just kind of making sure, figuring out what that is. They're trying to switch to answer your question, no, not all the time. We do operate off the same set of protocols, and it does work pretty well. Our folks work really well on the front lines together. But as far as continuing education goes, they just don't have the bandwidth to reach that. They're trying to do it through videos and things like that currently. But that's kind of how it works today.
Okay, thank you.
Yes. Any other questions about that? So we talked a little bit about the hospitals and the interfacility side. The hospitals have worked very closely with us on some of the programs that we've talked about to help the community, and we'll talk about that here in a little bit, but just this has come up a couple times as far as what the costs are and what the revenue looks like. So basically our cost per response is about $306.40. So every time somebody calls 911 over 2021 to 22, it was about $306.40. The revenue on the 911 side that we produced off of that was $463.22. So there's a pretty decent deficit we have there. That's across all payers. Again, I've put the payer mix information in your packets. Actually, I didn't put it in your packets, but you have the payer mix information. But our revenue per response for interfacility transfers is $526.29. In 2021 to 22, that was just under $9 million at the time of revenue that we generated out of that went back into the 911 system to support that system and some of the things that we do to help support that system. This year, it's over $10 million, I'm pretty sure is what we anticipate it to be. Again, it's about 10% of the call volume, but 17% of the revenue. And because we're structured the way we are, There's no stock shareholders or anything like that to go to. It just goes back into the system. So they've been, in the way that that works, just so you all know, and to be completely transparent about it, is those hospitals, when it is there, they sign contracts with us to be payer, what they call payer of last resort, and they end up paying about 300% of fair market value for the transfers that they do to help subsidize the system, basically, just to be blunt about it. Yes, sir.
Maybe two questions. What is it, what do y'all charge for a ride for a patient, for transport?
So for an ALS patient, it's somewhere around $1,800, give or take. I can't remember the exact fee schedule, but it's $1,800-ish, and I think it's $27 a mile.
Okay, and then as far as the payer mix, am I correct in reading this that looks like maybe 76% of the payer mix are individuals who are participating in Medicare, Medicaid, or bill patient, meaning I guess they don't have a billable insurance?
Yeah, so I believe that's correct. That sounds about right. The bill
Okay.
patient is around 25% of those that we pick up. That includes these interfacility transfers that, they all have a payer source.
Right.
Out of those folks, we normally collect about around $2.50, or 2.5% of what's billed. So that's not a great number. Medicaid, we typically lose money on, and depending on the call, Medicare, we may or may not lose money on.
That makes sense. And then as far as the individuals who aren't able to pay and end up being referred to collections, what does that collections process look like? And then is it a collections process that impacts their credit as well?
So if they are uninsured and they make less than 400% of the federal poverty level, which I believe for a family of four is $100,000 or so, we will write their bill off. They have to let us know that they qualify. We have some screening things we try to do, but obviously, if you don't tell me where you fall, I can't write your bill off. But if they're uninsured and they're in that situation, we write their bill off. If they have insurance and they have a deductible or something like that, we will charge them for that. If they don't pay it, we turn it over to collections, which does affect their credit. We do not do hard collections. We don't put liens on people's houses and things like that. Basically, it goes to collections, and that's that.
Does it impact their credit at all?
Yes, sir, it does.
Okay, great. And then not great, but, and final question is, with charging $1,800 and the cost being $300, I'm assuming the intention really is to try to create some cushion in the system, knowing that a certain percentage of the calls you won't be, or payers you won't be able to collect. Is that how we kind of get close to balance, or at least in terms of a goal, how do we get close to balancing a budget?
Yeah, so the reason, and anybody that's gotten a medical bill of any sort, not just ambulance, you go, why do you charge this?
Right.
The reason why you charge this is some of the commercial insurers pay it. Typically, the VA pays bill charges. They're debating about going away from that, but commercial insurers, some of the commercial insurers pay it. So if you're going to bill me $1,800 and I'm an insurer, or if I'm going to pay $1,800 and I'm an insurer, you want to make sure that you bill me $1,800, because if you bill me $1,500, you just missed the $200 that I was willing to pay. Medicare and Medicaid, for the most part, we have to write off that balance. We're not allowed to bill those patients, and so we can bill them $1 million if we want. They're only going to pay us $300. So that's why the charges end up being so much. In total, we collect about $410 per billed charge. Is out of all that, our gross charges are $2,000 that we bill. We normally collect around $410. It's
Okay.
probably the clearest way that I can say that. Yes.
And we can follow up and work with MedStar to get you more collection information and process.
We're running up on our time, so if you'll just hit the high points.
Yes, so, and we covered this a little bit, kind of our hospital work and community work, our 911 nurse triage system that we've used before. We actually don't do that any longer, but the high utilizer group we continue to work through, admission, readmission prevention for congestive heart failure patients, just doing education, things like that. We've had people come from across the world to see the mobile integrated healthcare products that we do and the innovative ways that we do medicine. The reason I bring that up is, and I know we're running short on time, is as we talk about 911 systems, the 911 systems are getting run down across this country, and it doesn't matter what city you look at. And I understand the underperforming comment because we are not hitting our response time metrics. However, of those cities that are reporting their response time metrics we've looked at, none of them are. It doesn't matter if it's fire-based, third service, public utility model, and it's because so many people, we're a safety net provider. I can't emphasize that, and I know I'm standing here having this conversation with an ad hoc committee about EMS to decide the future of EMS for Fort Worth, but it doesn't, that's why I say it doesn't matter what the model is, because everybody's trying to figure out how to deal with all these low acuity patients that are calling. We've had folks call for boils on feet. I promise I went to school. Feet in the last couple of days. And things like that. And I sent a $400,000 ambulance out to see these folks because the programs that we have without a funding source, it doesn't make sense because of the expense associated with sending all these these resources out. But if you don't have revenue to support the lower cost folks, that's what you have to do. You use the tools that you're provided with. And, as we've talked about, we've tried to be proactive about this, but you can only do so much when you're relying on other programs to help support diversion programs, basically. So one of the things that we've tried to do with this is make sure that we do scorecards. We use EMS Survey Team, which is a third-party provider. This is on one of our mobile integrated health programs. Typically, we've seen about a 50% reduction in readmissions for these folks and high utilizers with high patient satisfaction scores. Kind of our MedStar and city relationships, I think this was the last thing that I was asked about. We did COVID vaccine clinics throughout the community. We did that in partnership with Fort Worth Fire in some of the critical need areas and some of the suburban cities that wanted to see it. We did monoclonal antibody infusions for first responders and hospital overflow work. Basically, we've tried to step up and fill gaps anywhere we could, especially through the pandemic and things like that, to make sure that we're integrating as much as possible through churches and different community opportunities. And again, the mobile integrated healthcare programs provide a great conduit for that. We actually received some air conditioning donations throughout the summer, and we've been able to use those. Those folks are very passionate. A lot of the issues that cause them to abuse 911 are social issues. And so these folks are very well versed in social determinants of health and trying to reverse that. So all right. Happy to take any questions.
Okay. Any quick questions right now? Because we got to move on. All right. Thank you, Ken.
Thank you.
All right. We're going to have to wrap up the meeting. As I said before, the baseline response times and discussions, inevitably about reprioritization data will have to be carried over into our next meeting. So that'll be the first item then. Before we wrap up, there were, I think, at least a couple of future agenda type items. Valerie, do you have those in mind just to make sure that we capture?
I
those
do.
requests?
I have a list. We'll provide some more just clarity and definition on EMT versus paramedics, fire paramedics, a list of the not-for-profit EMS providers, just so you can have a handle on those. We'll pull some case study information on Charlotte and Indianapolis and some of those other public utility models. We'll start pulling dispatch models. We'll get you paramedic program and costs for the paramedics that the fire department has put in place this year. We'll get you more information on City of Burleson, details on medical directors, budget, and some of the parts that make that up, the details. Deployment of priority one calls in the service deployment model, so you can see that visually. And then collection processes for the non-insured write-off
Okay.
processes.
Does that sound right to everybody?
I had
Jared?
one more to add on to that
Okay.
too. Not just the nonprofit companies, but I think it's helpful to have companies that are in the marketplace that we're comparing, just so we can, if we need to reach out to them, we can,
Okay.
and to figure out exactly what they're doing and how they're doing it.
Okay, so all companies, both nonprofit and profit.
Yes, because for example, like City of Arlington, we can provide a copy of that contract that they have with their ambulance service provider to give some context of some of these in action.
Okay, Jared?
Yeah, just a clarifier for the collections piece. I think it'd be helpful to know the breakdown of how those, I guess, the determination of the collections.
Okay.
So like whether it was resolved and they paid, or how many were written off versus how many were sent into collection due to delinquency and impacted their credit. And then on the, I asked a question, I think you may have mentioned it, but just in terms of how much, I guess, quantifying the services that we are providing, because our fire are the first responders to these type of calls. And so what does that dollar amount look like?
And I had just one other thing, which was to add to our spreadsheet how long the systems were in place.
Correct. Thank you. Yeah. Okay. I think with that, we can adjourn.
Actually,
Oh, wait, do you have
one
more
last thing, just as we're setting up the response time conversation, because it's very important, that we want to set the baselines for this committee and for the public and everyone watching to understand that as we're going through these conversations in this committee work and working with MedStar, you're not going to see any changes in quality of the service that you're currently getting. Providing patient-centric services and top customer service is paramount to us. And understanding those response times will allow this committee to ensure that there's no backtracking or slipping. But we understand with the mayor and council that providing patient-centric services and reassuring residents and visitors and guests that services will maintain and be in good shape through this transition year as we work with MedStar.
And we will have packets to you earlier this time.
Yes. We'll make that adjustment. You're a fast reader anyways, right? Okay. All right. Thanks, everybody. Appreciate y'all. We are adjourned.
I saw it at like 11:30.
All right.
initially fixed,
Are you ready to go?
an amount which should be different.
Come on, Macy.
Sorry, yeah. I'm still on that.
Hey, she I had it on. Thank you. All right. All right, good afternoon, everybody. Welcome to the Central City Local Government Corporation Board meeting for Tuesday, September 12th. So let's go ahead and get started. Thank you, Elizabeth. All right, it sounds like I have a motion for the approval of June 27th meeting minutes. And a second. All right, all in favor indicate by saying aye.
Aye.
Aye, motion passes. All right, we have two staff reports. Financial report for the period of October 22nd, I'm sorry, 2022 through June 2023. Any questions on that? All right, moving on. Update to the sale of Magnolia Green Garage. Any questions on that? None? Okay, moving forward. We have a discussion and action items. This is about the Crescent parking garage, right? Okay, who is talking about that for? Is that you, Robert?
Yes, thank you, Councilmember Flores. I'm going to give you a brief intro to just remind you all of the context of this project, and then I'll turn it over to Alex Lawford to really get into the bond sale that we're proposing. This project was approved back in March of 2021, where the city and CCLGC authorized an agreement to fund an economic development program agreement and the intent to issue $25 million in bonds to facilitate the Crescent Hotel project. Again, just an overview of the concept plan for the development. And then the site located at 3300 Camp Bowie Boulevard, right there at Van Cliburn Way. So as you all recall, this is a project that we're doing at Crescent Real Estate. The developer is going to invest a minimum of $200 million in the project by June of '24, with $165 million minimum hard cost, 15% with their MWB spend, and a little bit over $1.2 million in enhanced streetscaping and public spaces. In return, they are going to develop and operate a 200-room, 4-star hotel, 8,500 square foot of meeting space, a 4,500 square foot restaurant. They would also have 150,000 square feet in office tied to their overall project, and a minimum of 2 parking garages, which a combined 825 spaces, and they would enter into a room block agreement for the project. So the previous proposals or presentations that were brought forward to you all contemplated that upon full project completion, the CCLGC would actually own these garages. So not unlike the Magnolia Green Garage, which the CCLGC also owns, this is really our opportunity to close the overall project financial gap. So this is a little bit different than our longer-term incentives. This is a purchase that we are doing, and we will hold that asset, those garages, as the asset for the project. So again, the purchase price would be the lesser fair market value, or $25 million. That would be facilitated through a debt instrument issued by the CCLGC and funded by the project, and that's what Alex is going to provide some details on. And then under the agreement, the CCLGC would lease the garages to the city, who would then sublease to the developer. So there'd be a 20-year lease term with 4 options to renew. The debt service would be paid by a combination of a fixed payment that we're receiving from Crescent, along with revenue that we're receiving from the parking garages. So we have a 25% split parking revenue in the first 5 years, and then that increases to 50% parking revenue split for the remainder of the project. And as part of the 825 spaces, 400 of those will be set aside for public use. So those will be available nights and weekends for the public to utilize those facilities. And so with that, unless there's any questions about the project specific, I will turn it over to Alex to talk about the bond issuance.
All right, Alex?
All right, good afternoon. My name is Alex Lawfer. I am the debt manager here at the city. And today we are seeking the consideration and approval by the CCLGC board to authorize the issuance of lease appropriation revenue bonds through negotiated sale for the purpose of purchasing the Crescent garages pursuant to the terms of the agreement that Robert just mentioned. Debt service on the bonds will be secured by the city's annual lease appropriation payment to the CCLGC, which is ultimately supported from underlying revenues generated from the project, including incremental property tax revenues, the sublease payment, and parking garage revenues. The resolution authorizes up to, I don't have the. So sorry about that. Here was the last slide. The resolution on the bonds authorizes up to $30 million of a principal, which will accommodate the purchase of the garages and related expenses for cost of issuance. We currently estimate the bonds to have an interest cost of about 6.37%. The bonds are to be amortized over a 20-year repayment period, and we currently estimate average annual debt service to be about $2.6 million. So following the board's approval, we will seek City Council consideration and approval of these actions on the September 26th council meeting. We are seeking credit ratings from Moody's and Fitch, and we are holding rating agency calls with them on September 21st. We are currently scheduled to sell the bonds on October 17th with a closing and delivery on November 17th. And with that, I can answer any questions that you may have.
Any questions from the board? Looks like none. Thanks, Alex.
Thank you, guys.
All right. B, any need for an executive session? Oh, we do need to do that. That is an action item. All right. This is an action item, so need to approve, these terms as described. Do I have a motion to that effect? All right, do I have a second? Second. All right, all in favor, indicate by saying aye.
Aye.
Aye, motion passes. Now, Jamie, no need for an executive session. Great music to my ears. Future agenda items, anybody? Don't see any. We are adjourned.
Hey, hey.